So we're going to talk about bio-RSA. It's quite popular, and we will see the latest publication, what are the benefits, the true benefits, and perhaps also we will emphasize some risk with bio-RSA. So we all know that the first reverse shoulder arthroplasty was designed by Paul Gramont in France in 1985. It was to solve an unsolved problem at that date. That was a cavity arthropathy. And it looked like this, the trumpet prosthesis, which was a fully poly humeral implant cemented into the humeral shaft. It gave promising results, but the design of the reverse prosthesis we know nowadays was in fact performed between 1991 and 1995, still by Paul Gramont and by a young engineer called Jean-Michel Péguet. And the concept of this reverse shoulder arthroplasty was twofold. First, to get a good bone to implant integration by stabilizing the center of rotation and also medializing the center of rotation. And second, getting a good forward elevation by lowering the humerus and then increasing the tension of the deltoid. For a couple of decades, surgeons were quite worried about the survival rate of reverse shoulder arthroplasty. But in 2019, Ernst Brunner et al. Published this paper showing quite good long-term follow-up with reverse shoulder arthroplasty, at least as equivalent as anatomical shoulder arthroplasty, even better, because it's now widely admitted that after 10 to 15 years, almost all anatomic shoulder arthroplasty get a complete glenoid loosening. Sometimes it's well tolerated by the patient, but then here in this paper, the longevity of reverse shoulder arthroplasty was up to 70% after 15 years of follow-up. As a consequence, the number of reverse shoulder arthroplasty has increased steeply in all countries, and as if you look at the Australian registrar, now a reverse shoulder arthroplasty accounts for almost 80% of the total of the shoulder arthroplasty implanted. And all indications push the popularity of the reverse shoulder arthroplasty, not only cavity arthropathy, but of course proximal humerus fracture, but also arthritis. Arthritis, because even in arthritic patient, you get an arthroplasty that has a good longevity. The worry we all have and had with reverse shoulder arthroplasty was notches, and in the early publication, the rate of notches raised up to 50%, which is completely huge. And by that time, shoulder surgeons were concerned about the progression of the notching up to complete loosening. In fact, it rarely happens. If you analyze Bossali meta-analysis involving more than 2,500 reverse shoulder arthroplasty, the rate of loosening, debonding of the metaglen is less than 2%. However, notch is a problem because if you get an impingement between the calcar and of the humerus and the lateral border, you will have immediate discomfort of your patient. And then you will get a restriction of the range of motion getting worse over time. So notch, an impingement between the calcar of the humerus and the lateral border is still a problem. That's why Pascal Boileau, in 2011, published this paper and introduced the concept of bio-RSA, namely bony increase offset. The idea was to put away the calcar of the humerus and the lateral border to diminish the rate of notches. So that was the published technique. The bone graft was concentric and was harvested from the humeral head and then introduced in a long pen metaglenoid that was introduced in the native glenoid. Another advantage of bio-RSA, so it in theory decreases the rate of notches, but also it increases the deltoid wrapping angle to provide a better function of your deltoid and then a better function of your shoulder. And also it horizontalizes the vector of force to have a better ingrowth of your prosthesis into the bone. So after a certain popularity of the bio-RSA, surgeons, especially Pascal Boileau, introduced the concept of eccentric graft to fill loss of bone, for instance, in case of severely worn out posterior glenoid. So the bone graft is not cylindrical, it's trapezoidal, and it fills the defect in the axial plane, but also in the sagittal plane. So this leads to use more and more bio-RSA in case of primary arthritis with severely worn out glenoid. And this meta-analysis published and analyzed all the published paper on bio-RSA and found that the rate of fusion of the graft was quite impressive with concentric bone graft, as initially described, but also with eccentric bone graft up to 90%, beyond 90%. And the function was also quite surprising. Forward elevation really increased, abduction as well, a little bit less the external rotation. And this is important, and that's why I want to focus on this point. Because reverse shoulder arthroplasty gained in popularity, because we had papers show good function, because they show good longevity, equivalent, also better longevity than anatomical shoulder arthroplasty. Some surgeons start to compare reverse shoulder arthroplasty and anatomical shoulder arthroplasty in case of arthritis without cuff tear, and shows that the results, the short-term results, were equivalent. A little bit less for reverse in rotation, but still quite equivalent. And the conclusion was, it's good even in young patients because the longevity of reverse seems to be better than the longevity of anatomic. But this paper points out the fact that even in reverse, it's better to repair the cuff if you can repair the cuff. And all is about the tension of the cuff. And one of the problems of using bio-RSA, if you just want to minimize the notches or increase the wrapping angle, is that you can over-tension the posterior cuff, the remaining posterior cuff. And not sure you can see the arrow here, but this is a bio-RSA, and the greater tuberosity was pulled out in the immediate post-op X-ray. Immediate because of an over-tensioning of the posterior cuff. So that's really the risk. And for me, the good landmark to see if we are not over-tensioning the posterior cuff is to be able to reattach the anterior subscap. However, in eccentric, when you use an eccentric bio-RSA for a posterior glenoid bone loss, then you recover the good tension of the cuff. So it's totally different. The problem is of course, to be able to restore the anatomy and to correct this glenoid bone loss. But I won't talk too much about that because we saw that this morning. First question is how to, what is the desired position? And we published that the glenoid vault outer cortex, so the plan of the neck is perpendicular to the maximum bone stock axis, and in normal patient is parallel to the surface layer. So this is a better landmark than the Friedman landmark or the scapular blade landmark, whatever the patient age is. And how to get the maximum bone axis, you've got, of course, navigation with PSA, because without PSA you could not achieve what you plan, or navigation, or for the future is perhaps HoloLens. It is not that yet, but we've got this glenoid position clamp, and we believe it drives us to the good orientation and allow us to do some good eccentric bio-RSA. So in conclusion, bio-RSA, the rate of fusion is not a problem. Osteolysis of the graft is not a problem. It provides significant improvement in forward flexion and abduction. My message is to beware about concentric graft bio-RSAs that could overtension your posterior cuff and leads to pain, stiffness, and pull out of the insertion of the posterior cuff. However, I'm totally comfortable with eccentric bio-RSA to restore the anatomy, the pre-erosion anatomy, and I use the GPG to do that. Thank you very much.